What I'm going to be talking to you about today is targeted therapy of IDH1 and IDH2 mutated acute myeloid leukemia. What's interesting about mutations in isocitrate dehydrogenase, which come in two flavors, IDH2 mutations and IDH1 mutations, is that they predominate in different kinds of malignancies. IDH2 mutations are more commonly found in hematologic malignancies, and IDH1 mutations are more commonly found in solid tumors. Among IDH2 mutations, the most common mutation in myeloid malignancies is the R140 mutation, and the most common mutation in lymphoid malignancies is the R172 mutation. IDH2 mutations occur in approximately 15% of patients with AML and in approximately 7.5% of patients with AML who have IDH1 mutations. As mentioned before, isocitrate dehydrogenase is a critical enzyme in the citric acid cycle. Mutant IDH2 occurs in approximately 12% of patients with AML and produces an oncometabolite called 2-HG, which alters DNA methylation and leads to a block in cellular differentiation. Enasidenib, also known as AG221, is a selective, oral, and potent inhibitor of the mutant IDH2 enzyme. The way enasidenib induces differentiation of leukemic cells is by blocking the mutant IDH2 enzyme, leading to lowering of levels of intracellular beta-2-HG or beta-hydroxyglutarate, and the lower levels of intracellular 2-HG or beta-hydroxyglutarate allow the cell to differentiate and allow those blasts to turn into healthy adult mature neutrophils. So based on this preclinical hypothesis, we conducted a large phase 1-2 study of enasidenib in patients with relapsed and refractory acute myeloid leukemia. The study started with a dose escalation phase, as you can see on the left-hand side of the slide. It expanded into a dose expansion phase with 4 different expansion arms, the first 2 of which were in patients with relapsed and refractory AML. And finally, there was a phase 2 expansion that enrolled patients only with relapsed and refractory AML at a dose of 100 milligrams once a day. The baseline characteristics of the patients treated on the study are shown here. You can see that of the patients with relapsed and refractory AML, which are the first 2 columns, the median age of the group of patients was 68 years old, both in the patients with all doses and in the patients getting 100 milligrams once a day. The predominant mutation was the R140 mutation compared to the R172 mutation, and if you scroll down to the bottom, you can see that most of these patients really were a poor risk group of patients in that they were either refractory to initial induction or reinduction treatment. They had relapsed within 1 year of initial treatment, they had relapsed post-transplant, or they were in second or later relapse. The co-occurring mutations that occur in the different types of IDH2 mutations are shown below. You can see that there are more co-mutations in patients with R140 mutations, fewer co-mutations in patients with R172 mutations, and the spectrum of mutations seen in each different subtype of mutation differs. So those patients with R140 mutations more commonly have SRSF2 and DNMT3A mutations, while with the R172 mutations, the most common co-occurring mutation is DNMT3A. The response in patients with relapsed and refractory AML is shown on this slide. You can see that in the group of patients who received whatever dose of the drug, the overall response rate was 38%, with a complete remission rate of 19.6%. The CRI and CRP rate was 7.8%, partial remission rate of 5.7%, and morphologic leukemia-free state of 5.3%. This is a drug that takes time to work. The time to first response was 1.9 months. The time to CR or best response was 3.8 months. What this translates into on the next slide is that in relapsed and refractory AML, the median overall survival for all the patients in this group was 8.4 months, with a median follow-up of 6.6 months. If you look at the overall survival by best response, you can see that the median overall survival is 22.9 months in the group of patients who had a complete remission. It was 15.1 months in that group of patients who had a response, but it was a non-complete remission response, and those patients with no response had a median duration of response of 5.6 months. This shows you how the responses evolve over time. As I mentioned before, it takes time for this drug to work. You can see that most responses, given in the orange or the green, occurred between 3 and 7 cycles of treatment. We know that differentiation is the mechanism of action of this drug, and that is illustrated by the next 2 slides. This slide here shows a patient who had screening at 44% blasts, was thrombocytopenic and had neutropenia. At cycle 2, day 1, their blasts have gone down to 12% without any intervening period of thrombocytopenia, neutropenia, or hypocellular marrow. with the platelets rising to 106 and the ANC rising to 1.3. We can also show this by cytogenetic and molecular methods. You can see that in this patient who had a trisomy 8 on the top, as those blast cells matured, going from blast to mature granulocytes in the first 3 panels, you can see that trisomy 8 persists from the blast stage all the way through to the mature granulocyte stage, where you can still see the 3 red signals for trisomy 8. And of course, in the lymphocyte compartment, there is no trisomy 8 as one would expect. Similarly, you can look for the R140 mutation at screening, which is shown below on the left. And then if you then look at the time that those blasts have differentiated into neutrophils by cycle 3, day 1, you can also find the R140 mutation in those cells. So based on all of this data, the FDA granted regular approval to enasidenib for the treatment of relapsed and refractory acute myeloid leukemia on August 1st, 2017. There have been some question about what happens if the IDH2 mutation is subclonal, that is, there's a low variant allele frequency. You can see that in this slide here, even in those patients who had a low variant allele frequency, that is, patients with a complete remission and patients with a response that were not a complete remission, there are still patients, even though they have a low VAF, who respond to treatment. So the presence of a low VAF in and of itself is not enough to say that the patient is not going to respond to treatment. It likely depends also on the co-occurring mutations. So in conclusion, differentiation therapy offers the possibility of treatment without cytopenias and death and aplasia. IDH inhibitors represent differentiation therapy that I think is akin to ATRA and arsenic. Some unique features of IDH inhibitor therapy include prolonged time to response, like hypomethylating agents, and we do see, which I didn't talk about, a differentiation syndrome with this drug. Resistance, we think, is mediated by clonal outgrowth and evolution, and combination approaches are needed to overcome this resistance. That includes combination approaches with an IDH inhibitor and a FLT3 inhibitor, and combination approaches with an IDH inhibitor and a MEK inhibitor. Thank you for your attention.